Okay, this is the continuation of the discussion on respiratory distress, and in this part I'm going to spend most of the time talking about barotrauma or extra-alveolar air or air block syndrome, whatever term you choose to apply. But the first couple of cases I'm just going to show you examples of atelectasis. Babies that have been intubated for a while, or even if they have never been intubated, often develop problems with mucus plugging. So if you see a focal area of increased density or even increased density in the entire lung, it's almost always going to be a result of atelectasis. There's no reason to raise the possibility of infiltrate or pleural effusion or anything like that. So this first patient is a patient that had cardiac surgery recently and was recently extubated, and you can see there's asymmetry of the lungs with the right appearing much more opaque than the left. And this is just generalized atelectasis involving most of the right lung. It's not complete collapse because you can still see there is some lucency there. If it was complete collapse, the density of the lung would be the same as the liver. This is the same patient the very next day, and now you can see that most of the right lung has reinflated except for remaining atelectasis in the right upper lobe, and now he's got complete collapse of the left upper lobe. The patient is perfectly straight, and you've completely lost the mediastinal and cardiac border, and that's classic for complete collapse of the left upper lobe. This is a patient with complete collapse of the right upper lobe, and I'm only showing this because for some reason in newborns that I've never seen an explanation for, when you get complete collapse of the right upper lobe, the minor fissure maintains its normal position for some reason which I can't explain. Because you know this right upper lobe is completely collapsed because it's completely water density, the same density as the liver. So don't let that make you think you're dealing with a pneumonia, classic for complete collapse of the right upper lobe in the newborn period. Another patient with a focal area of increased density at the right base, and it is obscuring the right heart border. This is probably mild atelectasis in the right middle lobe. This is the same patient the very next day, and now you can see his right middle lobe is probably re-expanded. You can see the right heart border, and now he's got complete collapse of the right upper lobe, as well as the right lower lobe with loss of the right hemidiaphragm. This is a patient whose lungs were completely symmetrical just the morning before, and this was an x-ray done because of a change in the respiratory status, and you can see there's complete collapse of the left lung with significant mediastinal shift to the left. There's complete collapse of the right upper lobe, and in this case you can see the minor fissure is elevated, but that's probably because of the tremendous compensatory overinflation of the right middle and right lower lobes. This is another premature infant with what looks like pulmonary edema, and there's slight asymmetry in the density of the upper lobes, with the right slightly worse compared to the left. Incidentally, you can also see he has a massive pneumoperitoneum from GI tract perforation. This is the falciform ligament being outlined by the air in the peritoneum. This is the same patient the next day. You can see he's had a drain placed into his peritoneal cavity for the perforation. And again, you can see there's mild atelectasis in the right upper lobe and more significant atelectasis involving the left upper lobe and maybe to a lesser extent the left lower lobe. This is a patient with complete collapse of the right lung. Even though he's intubated, they can still develop mucus plugs. You can see there's tremendous mediastinal shift to the right despite the rotation to the right. There's no real reason to implicate a pleural effusion here, especially if there was never a central line on that side. He's had cardiac surgery. That's what these clips are from, and a previous right thoracotomy as well. The right thoracotomy, additionally, was because he happened to have esophageal atresia, and that was repaired, and then his tetralogy of Fallot was repaired after that. Now I'd like to present many examples of what you will see in a patient on a respirator often that develops extra-alveolar air or barotrauma. All barotrauma initially starts because of areas of interstitial emphysema, and this is the least common example of interstitial air, and that's when you have focal rounded areas of lucency that look like air-filled cysts, but there's no reason to suspect a congenital cystic lesion like CPAM. Generally, those patients are already known before birth because of the maternal ultrasound that usually reveals these lesions, but generally if you see a patient that has a rounded or multiple rounded cystic lesions, always consider that it's focal interstitial emphysema before you start thinking of congenital etiologies. There's a different patient with the same problem. There's an oval or rounded lucent area in the right suprahilar region, focal interstitial emphysema. There's another patient with the same problem. In this case, it's very medial in the left lower lobe, paraspinal. This was persistent on multiple films and is an unusual collection of coalescent interstitial emphysema in the left lower lobe. He may have other areas in the mid-lung field as well. A more common appearance of interstitial emphysema is to have either small cystic or linear areas of lucency. And this case right here is probably the most important one for you to remember. If you look at the lung bases in this patient, you might think that you're looking at air bronchograms in this area. But if these are air bronchograms, you ought to see the exact same number and size of air bronchograms in the corresponding area of the contralateral lung. So this, to me, is an example of very early interstitial emphysema, probably in the right lower lobe, because it does not look the same as the same area of the left lower lobe. And this is that same patient the next day, which sort of proves now he has a very large pneumomediastinum lifting up the right and left lobes of the thymus. The interstitial air may have disappeared, which it often does. Sometimes interstitial air will just disappear completely, or it may decompress as a pneumomediastinum or a pneumothorax, or even worse, examples of which I'll show you later. There's a different patient that has very localized interstitial emphysema. Interstitial emphysema, even if it's subtle, is not difficult to diagnose when it's asymmetric, as in the previous case as well as this case. If you'll notice, there just appear to be small bubbles in the mid portion of the left lung. I don't know if they're in the upper lobe or the lower lobe, probably the upper lobe. And I don't see the same lucencies in the same part of the contralateral lung. So this is very early asymmetric interstitial emphysema. And the only reason why it's important for us to diagnose it at this level is that if they continue with conventional mechanical ventilation in the face of interstitial air, it's just going to set up a vicious cycle of the lung getting less compliant, so they have to deliver more pressure, and you eventually end up blowing out the lung and getting a pneumothorax. So if we can pick it up early like this, they will usually change the baby to a high-frequency ventilator, which causes less of a pressure effect on the lung and decreases the risk of pneumothorax, as well as intracranial hemorrhage, which is a common complication of pneumothorax or tension interstitial emphysema. This is a more dramatic and obvious example. This is a patient that has interstitial emphysema pretty much throughout the right lung, but particularly in the mid and lower lung field. Again, some of these look like air bronchograms, but you don't see the exact size and number of air bronchograms in the contralateral lung. So this is linear and some cystic interstitial emphysema involving the mid and lower lung field, and to a lesser extent the right upper lobe, because the whole right lung looks more lucent than the left, and it doesn't appear to be a result of technical reasons. This is a patient that has very fine interstitial emphysema, pretty much confined to the left lower lobe, and you can see it has already resulted in a large left pneumothorax with some tension and mediastinal shift to the right. The right lung basically just shows hyaline membrane disease with few air bronchograms. This is another more obvious case. There's clearly asymmetry in the density of the two lungs. The left diaphragm is flatter than the right, and you can see there are focal, linear, and cystic lucencies, particularly in the lower lobe, but probably in the left upper lobe as well. So this is more of a complete unilateral interstitial emphysema. There's no interstitial emphysema in the right lung in this case. This case isn't subtle. There's obviously a large tension left pneumothorax with mediastinal shift to the right. Notice the patient is not rotated at all. And you can see there's coalescent areas of interstitial emphysema in the left upper lobe. The left lower lobe and the lingula are probably free of any interstitial air, but obviously at some point there was rupture across the visceral pleural surface, giving you the tension left pneumothorax. Another patient with diffuse interstitial emphysema throughout the entire right lung, which is under some tension. You can see the right diaphragm is flattened compared to the left, and allowing for the fact that he's rotated slightly to the right, there is definitely mediastinal shift to the left. So this is tension interstitial emphysema with no definite pneumothorax seen on this examination. There's a different patient with the same problem on the left side. There's diffuse tension interstitial emphysema involving the left upper and left lower lobes with mediastinal shift to the right. Although unusual, this is the exact same patient I just showed you. This is an x-ray done the very next day, and you can see that all of the interstitial emphysema that was present throughout the left lung is completely resolved, and it resolved without the development of a pneumothorax or a pneumomediastinum. It's unusual, but it can happen. This is a less severe case, although he also has diffuse interstitial emphysema involving the entire lung on the right side, under tension because the diaphragm is flat. He has mediastinal shift to the left because if you'll notice he's actually turned to the right and his mediastinum is to the left. This patient has very fine lucencies seen throughout the left lung, and again there's some degree of tension here because the diaphragm is a little bit flatter than the right side. You know, even though this is relatively subtle compared to some of the examples I've shown, you really need to diagnose it at this point. This is that same patient the very next day, and you can see there's been dramatic progression of the degree of interstitial air, more tension with the diaphragm basically inverted, and a large focal collection of interstitial emphysema in the medial portion of the left lower lobe. It almost looks like a pneumopericardium, but it's not because he did survive this episode. This is an example of one of the most dire presentations you can see, although this baby actually did survive, but he's got diffuse interstitial emphysema, very symmetrical throughout both lungs. Often this is a premorbid findings, but as I said, this patient actually survived. But just also be aware that when you have such tension, as an example like this, that causes increased pressure in the jugular venous system and is a precursor for intraventricular hemorrhage in the severely premature infant. This is a less severe example in that the right mid and lower lung field are spared, but you can see he's got diffuse interstitial emphysema throughout his left lung as well as in the right upper lobe. I should have apologized up front that I showed so many examples of the same thing, but if I just showed you one classic example of something, it wouldn't mean anything to you, so I like to show several different patients and the variations on a theme. I'm going to spend some time now talking about pneumothorax. I've shown you several obvious pneumothoraces already. This is another patient where you obviously see the edge of the lung with air lateral to it in the pleural space. But unfortunately, most pneumothoraces aren't this obvious, so I have to show you the more subtle examples that you need to look for. But just be aware that in addition to the area you see lateral to the lung, this whole lucent area medially is also an anterior pneumothorax. The fact that you see the posterior recess so lucent means there's a lot of air under the lung as well. So this is a lot bigger pneumothorax than you can really imagine. If you ever really want to know the size of a pneumothorax, you really have to do the contralateral decubitus view. Different patient with a large right pneumothorax, and no one's going to have a problem diagnosing it. You can see the visceral pleura all the way around the edge of the lung, including the bottom of the lung. But unfortunately, this is not always going to be seen with even a fairly large pneumothorax. This is a patient with very large bilateral pneumothoraces. There's clearly a subpulmonic pneumothorax on the right side, but in addition, the heart border should never be that sharp. So there has to be air outlining the medial aspect. That's outlining the cardiac border, so there's a lot of anterior air here. The same is true on the left side. You can see the visceral pleura laterally and maybe subpulmonically, but this whole area is too lucent and this heart and thymic border are much too sharp. So these pneumothoraces are both a lot larger than you initially think looking at the radiograph. Sometimes a pneumothorax can be confined to the subpulmonic area only. This is air under the lung, pushing the base of the lung superiorly. If you'll notice, the rest of the lungs have a very symmetrical appearance. And just a word of warning, if you happen to do a right lateral decubitus view in this patient, it may not necessarily, the air may not necessarily go out over the edge of the lung, but that does not mean it's not a pneumothorax. Because of the sharp angle of the edge of the lung here, sometimes the air pushes up against the rib cage and the air gets caught under the lung. Often if you do the contralateral decub, in other words, if you did a left lateral decubitus, then you would see the air layer against the mediastinum. This is a patient that clearly has the endotracheal tube in the right main stem bronchus, and he has a large right pneumothorax. You can see that the posterior recess is much more lucent than you can see on the left side. So there's air under the lung. I think you can see the base of the visceral pleura right here. But in addition, the whole hemithorax just looks much more lucent than the left side. So this is a larger pneumothorax than you might first think when viewing for leaving the annotation on this particular patient. The a resident was measuring the distance between the edge of the upper lobe and the inner margin of the ribs. But it has nothing to do with the size of the pneumothorax. Yes, this is the visceral pleura, but notice that it's much too lucent medially. This heart border is much too sharp compared to the contralateral heart border. As I said earlier in my earlier talks, generally the lungs are symmetrically involved, so if the heart border is a little bit indistinct on one side, it should have the same degree of indistinctness on the contralateral side. So often air medially will make the heart border look sharper on the side where you have a medial pneumothorax. This is the right lateral decubitus view on that patient. You can see the sheaths folded up against his right chest wall, and you can indeed see that this pneumothorax was a lot bigger than you thought it may have been just on the basis of how much visceral pleura you could see laterally. In other words, don't sit around waiting to see a visceral pleural line, because you're probably going to miss 50 or 60% or more of the pneumothoraces in a supine neonate. So this is a moderate to large left pneumothorax. It doesn't appear to be under tension. This is probably the most common manifestation of a pneumothorax in a supine neonate, and that is a so-called medial pneumothorax. You can actually see the visceral edge of the right lung. There is no pleura seen laterally. There's probably a little pleura inferiorly, and in fact you can see the posterior recess is too lucent compared to the contralateral side. So this is a small to moderate medial right pneumothorax. If you'll notice, he already has a chest tube in place with the residual pneumothorax. There's a patient with an obvious large right pneumothorax. You can see the visceral pleura, which you don't need to see, as I already told you. But on the left side, if you'll notice, there's a medial hyperlucency, and the heart border on that side is as sharp as the heart border on the other side. So this is bilateral pneumothoraces, very large on the right and probably small to moderate size on the left. There's a patient also with a medial pneumothorax. You can see the difference in the degree of lucency of the medial hemithorax compared to the lateral hemithorax. In this case, you can actually see what appears to be herniation of the mediastinal pleura across the midline, even though there's not a large degree of tension in this particular case. Different patient with the same manifestations. There's a medial lucency with a very sharp left heart border. This should not be confused with a pneumomediastinum, because usually with a pneumomediastinum, no matter how small the thymus is, you will see the lobe of the thymus on that side lifted up. So this is another medial pneumothorax, probably small to moderate in size. You can see the medial edge of the lung here with a hyperlucency medially, and the heart border is much sharper than the heart border on the contralateral side. So another, I'd say, moderate size medial left pneumothorax. There is no visceral pleura inferiorly or laterally. You don't have to see that. This patient has medial lucencies on both sides, small on the right, outlining the right heart border, a little bit bigger on the left side. Bilateral medial pneumothoraces, left greater than right. This is a patient whose whole right hemithorax looks more lucent than the left side. There's no significant mediastinal shift here. There's no real asymmetric flattening of the diaphragms, but whenever you see a unilateral hyperlucent lung, always think of an anterior pneumothorax. It's possible in a patient like this that it could just be an overinflated right lung, either on a compensatory or obstructive basis. But whenever you see a unilateral hyperlucent hemithorax like this, you ought to just go ahead and get a decubitus film to rule out a pneumothorax. They didn't do a decubitus film, but this is that same patient the very next day, and now instead of being diffusely anterior to the lung, now it's all medial, and you're seeing the medial edge of the right lung as well as a very sharp right heart border. So it went from being a, quote, unilateral hyperlucent hemithorax to just a medial hyperlucency. There's another example of a unilateral hyperlucent lung. The whole left lung looks more lucent compared to the opposite side, and look how much sharper the heart and thymic borders are compared to the right side. So sometimes you won't see a medial lucency or a subpulmonic lucency, or certainly the visceral pleural laterally. Sometimes it's just a unilateral hyperlucent hemithorax. And again, if you want to confirm it, you have to do the opposite decubitus view. This is my very case of a unilateral hyperlucent hemithorax that was read on the outside as a 3% pneumothorax because I think they saw a little bit of a visceral pleural line right here. But again, the whole hemithorax is hyperlucent. There's some herniation of pleura across the midline. I'll just tell you, the neonatologist knew better and ordered a left lateral decubitus view of the chest the next day. This is the left lateral decubitus. You can see it's a little bit more than a 3% pneumothorax. It's fairly large. As I said, most neonatologists are perfectly aware that you really can't quantify a pneumothorax without getting a decubitus view, because you'll be fooled more often than not. This is the last example of pneumothorax I'm going to show you. The only evidence here is that the posterior recess is much better seen, more lucent than the opposite side, and you have this line here that you need to explain, which is herniation of mediastinal pleura across the midline. So this is another example of unilateral hyperlucent lung. However, in this case, you can see evidence of a pneumothorax by the lucency of the posterior recess and the herniation of mediastinal pleura across the midline. Now, briefly regarding pneumomediastinum. More often than not, a pneumomediastinum will lift up the lobes of the thymus. This is the left lobe lifted up off of the heart. This is the right lobe lifted up off of the heart. You can see air dissecting in the soft tissues of the neck. Frequently, a pneumomediastinum and pneumothorax coexist, not in this particular case, nor does pneumomediastinum have all the serious implications that a pneumothorax can have. It should not lead to a tension phenomenon or increased pressures in the jugular venous system that may lead to a IVH. This is a more dramatic example of a large pneumomediastinum lifting the right lobe off of the heart, lifting the left lobe off of the heart, and I don't really see an associated pneumothorax here. Again, generally, hemodynamically, pneumomediastinum should not really interfere with function or lead to serious problems in the respiratory status of the neonate. There rarely will be such a thing as a tension pneumomediastinum. Generally, they're self-limited and will disappear on their own. This is a patient that happened to have a left pneumothorax. You can see there's air outlining the basal visceral pleura, outlining the lateral pleura over the left upper lobe, and then here's a lucency lifting up the left lobe of the thymus. So it's a left-sided pneumomediastinum as well as a left pneumothorax. A similar patient with a large pneumomediastinum lifting up the right and left lobes of the thymus, and he also happens to have a large or moderate-sized medial right pneumothorax, and there also is some air outlining the inferior visceral pleural surface. This is a less common manifestation of pneumomediastinum, and that's when you have air that's in the posterior pneumomediastinum behind the heart, and it often looks like a lucency that points towards the esophageal and aortic hiatuses. And if there wasn't an NG tube, you would actually see the esophagus as a water density tube surrounded by all this air. The significance of a posterior mediastinum also should not lead to any problems, except it occasionally can dissect through those hiatuses into the retroperitoneum and the peritoneum and give you a pneumoperitoneum, in which case then you have to decide, is that air in the peritoneum coming from a perforated viscus, or is it simply dissecting from the posterior pneumomediastinum? A posterior pneumomediastinum will also dissect in the soft tissue of the neck, as you see here, and this patient also happens to have both focal, large rounded areas of interstitial air as well as linear interstitial air. There's also focal interstitial emphysema in the left hilar region as well. There's another patient with what looks like a posterior pneumomediastinum surrounding the nasogastric tube. In this case, also has focal interstitial emphysema in the medial aspect of the right lung, and you can see air dissecting into the soft tissues of the neck. The most serious consequences of interstitial air are the development of a pneumopericardium, which can lead to pericardial tamponade, as well as the most serious complication, which is air embolus because of massive intravascular air as a result of interstitial emphysema. Here you have a patient that obviously has a lucency that's outlining the heart, outlining the inferior aspect of the heart, And this is probably a pneumopericardium, but I'm only showing you this with the caveat that a pneumomediastinum can actually outline the inferior aspect of the heart on the frontal view. But as I'll show you in the next case, the way to differentiate a pneumopericardium from a pneumomediastinum that's outlining the inferior margin of the heart is to do a lateral view of the chest. And I'm going to show you an example in a somewhat older infant that makes that point. This is a 4-month-old that was in the pediatric intensive care unit with respiratory failure, and you can see that he developed a lucency surrounding the heart, outlining the inferior margin of the heart. And as I just said, sometimes a pneumomediastinum can look like this, and that's when you need to resort to a lateral view, which I'll show you next. Okay, this is the cross-table lateral view of the patient I just showed you, and if you'll notice, the air is outlining the inferior margin of the heart all the way to the back. If this was a pneumomediastinum, because the central tendon of the diaphragm and the parietal pericardium are intimately adherent and cannot be dissected away from each other, a pneumomediastinum will not extend beyond about this point. If you see air that goes all the way back and outlines the inferior margin of the heart all the way to the posterior aspect, it has to be in the pericardial cavity, and obviously is much more import than if it was a simple pneumomediastinum. As I alluded to, this is probably the most serious and usually fatal complication of interstitial air. If you'll notice, this baby has fairly mild interstitial air, pretty much confined to the right lower lobe, but he's got a large amount of air in the right atrium. There's air in the main pulmonary artery. This air, I think, is probably refluxing into the right jugular vein. That's too big to be the carotid artery. And usually these infants die shortly after the radiograph is taken.